Hi, I'm Dr. David Cody and I'm going to take you through knee examination. Adil's here to help me. One of the first things that I wanted to say was that it's important to make sure that the couch is at the right height. I often see medical students struggling to examine the joints, particularly when the patient's on the couch because they haven't got it at the right height. Ideally, you want it about hip level or just below for when you're examining either the hip or the knee. Firstly, I'd look initially from the end of the bed for loss of symmetry and loss of normal leg alignment, such as a varus deformity, where distal to the knee is deviated medially, leading to bow-legged appearance, or a valgus deformity, where distal to the knee is deviated laterally, leading to a knock-kneed appearance. I'll lift up the heels and just make sure that both knees fully extend and there's no fixed flexion deformity at the knee. I'll look at the quadricep muscle bulk. I'll look at the knee itself for any swelling of the knee that I might see, particularly in the medial compartment. And I'll look over the rest of the lower limb, particularly for things such as scars or rashes such as psoriasis. The next thing I'm going to do is to palpate the knee, and for that the first thing it will be assessing temperature. So I'm just going to feel above the joint itself and below the joint line, and I'm just going to compare one side to the other. Next thing I'm going to do is to feel around the patella. So it's quite common that patients might get some patella insertional pain and tenderness. So there's the superior border of the patella and the inferior border of the patella, which should be palpated. And I'll also feel around the back of the knee for any popliteal swellings or cysts. Next thing I'm going to do is a patella tap. So this is a simple way of seeing if there's any fluid within the knee joint itself. Now, there may be a bulge on the inside aspect of the knee, but what I would do for a patella tap is I would put my hand above the knee in the area of the suprapatellar bursa, and I would squeeze downwards, and then with either my thumb or 2 or 3 fingers I would physically push down on the patella and see if it bounces. Now what we would get if it was a positive patella tap is a sensation of the patella hitting the femoral condyle, and this needs just the right amount of fluid. Too much fluid and you won't get that tapping sensation. Too little fluid and again you won't get that tapping sensation. For smaller amounts of fluid, what's sometimes useful is the cross fluctuation or bulge test, and for this we're looking for a bulge of fluid on the inside aspect of the knee in this medial condyle area. What we're going to do is we squeeze any fluid out, we milk it up. I often use the back of my hand round over the suprapatellar bursa and down the lateral gutter, and if you get a positive test you'll see a bulge of fluid emerging in this medial gutter of the knee. Next I'm going to bring the knee up to 90 degrees, and again I'm going to have a little feel with the knee at 90 degrees. What this does is this opens up the joint line, so I can feel with both thumbs. Again I can feel the infrapatellar tendon, I can feel its insertion on the tibial condyle, and then I can feel into the joint line, round to the medial collateral ligament and round to the lateral collateral ligament. I'll also again feel around the back of the knee and just make sure that the hamstrings are nice and relaxed and there's no tenderness there. Next we're going to do movement. So I'll ask initially active movement, so I'll get you to bend your knee all the way up and straighten all the way out, and we'll compare one side to the other and back, and then I'm going to do that for you. So for this, I would put a hand on the knee itself, on the top of the patella, and be feeling for crepitus while I do that movement. Anterior draw test. With the knee flexed to 90 degrees, the knee should be viewed from the side. Come down and make sure that there's no posterior sag of the knee, because that might indicate a problem with the posterior cruciate ligament. And then I'm going to put my fingers onto the hamstrings, make sure they're nice and relaxed. And I'm going to put my thumbs onto the tibial condyle as such, and I'll use my elbow here to brace the lower leg and then pull gently, and I'll watch the patient's face to make sure that there's no pain or discomfort. If it's a positive test, I'll feel a certain movement at the knee coming forward. Next I'm going to do collateral ligaments. For this I'll bring the knee just to about 15 degrees just to unlock the knee. And then I'm going to put the patient's foot on my hip and hold it with my elbow on the inside, as so. And I'm going to use my left hand, pushing on his lateral collateral ligaments, and this will be stressing the medial collateral ligament. So I'm pushing this way, and again I shouldn't feel any movement. And then for the lateral collateral ligament, I'm going to be pushing on the medial side, and I'm going to be pushing this way, and again I can feel no movement. I'll then get the patient off the couch and I'll inspect them again in stance just to see what they're like weight bearing and what the knees are doing, whether there's any varus or valgus deformity again. It allows me to look at the quadriceps muscle, and it allows me to look at the lower limb as well. So I'll look from the front again. Can I turn it to the side? And again I'll look at the popliteal area and all the way around. And again I'll look at hamstrings, popliteal, and also both calf muscles. So for function, I'm going to get the patient to walk, and for this I'll be looking at symmetry again and see if there's any evidence of a limp, see if they've got normal extension of their knees during gait, and I like to do this from watching the patient from in front walking towards me. So Adele, if you could walk for me. And that's the knee examination complete.